Welcome back to another deep dive. Today we're getting into something pretty complex, but really crucial for horse owners and, well, anyone involved with horses, even though it's quite rare, thankfully. We're tackling equine pemphigus foliaceus, PF for short. Our plan today is to sift through the research, the vet notes you've shared, and really get to the core of it. We want to make clear what PF actually is, how you'd see it affecting a horse, how vets figure it out definitively, and importantly, what the treatment looks like. Think of this as your shortcut to getting up to speed on a pretty serious equine health issue.
That's a great way to put it. And while, PF isn't common overall, it is the most common autoimmune skin disease we actually see in horses. Understanding that it's autoimmune, that the horse's own system is involved, that's really the key to figuring out why it acts the way it does and why managing it is, well, such a challenge.
Okay, perfect starting point. So let's unpack that. What exactly is equine pemphigus foliaceus? What's happening deep down?
Right. So at its heart, PF is a serious autoimmune skin condition. Basically, the horse's immune system gets its wires crossed. Instead of just fighting off infections, it mistakenly starts attacking components of the horse's own skin cells. And this attack causes a breakdown in how those skin cells stick together. What you see on the outside are those characteristic superficial blisters, crusts, and patches of hair loss. In some vet practices, after purpura hemorrhagica, it's actually considered the most common non-infectious cause of crusting.
Wow, so the body turning on itself, that's, fundamental. How does that actually work at that tiny cellular level? What's going wrong? What's the mechanism?
It's what we classify as a type 2 hypersensitivity reaction, which, maybe more simply put, means the body starts producing these things called autoantibodies. Think of them like friendly fire antibodies that attack the self instead of invaders. In PF, these autoantibodies mainly go after a protein called desmoglein-1 or DSG1, and DSG1 is a really vital part of structures called desmosomes.
Desmosomes.
Okay.
Those sound important.
Oh, they absolutely are. You can picture desmosomes as a tiny, super strong spot welds holding the main skin cells, the keratinocytes, really tightly together in the outer skin layer, the epidermis. Now, when these misguided autoantibodies latch onto DSG1, they mess up the desmosome function. The spot welds fail. And that leads to a process called acantholysis.
Acantholysis. Okay, what does that mean practically for the skin cell?
It means those keratinocytes lose their connections, they sort of round up and essentially just float free within the epidermis, detached from their neighbors. This loss of connection creates these little fluid-filled gaps, which form very superficial and really, really fragile vesicles. Those are the small blisters and sometimes larger ones called bullae.
So just to be super clear for everyone listening, vesicles are tiny blisters, bullae are bigger ones.
Exactly.
And you're saying they're so fragile they burst almost immediately, which is why we don't often see them.
Precisely. They're right near the surface, so they rupture very easily. And that's why what we usually end up seeing aren't intact blisters, but rather the aftermath. That means thick, often yellowish crusts, scales, maybe some red raw spots we call erosions, and secondary hair loss or alopecia. You also get a buildup of inflammatory cells, mostly neutrophils, sometimes eosinophils, within these spots, forming pustules.
It's quite something how the immune system can get derailed like that. Okay. Which leads to the big question. What starts this? Do we know the trigger?
That's often the million-dollar question. Frequently, the trigger is idiopathic.
Meaning unknown.
Exactly. We just don't know. But we do have suspects based on observations and research. Things like certain medications, specific drugs, maybe even vaccines in some cases. Sometimes bacterial or viral infections seem to precede it. Environmental factors could play a role too. Think insect bites, chronic inflammation or hypersensitivity, maybe even UV light exposure. There's also a thought that genetics might be involved, or predisposition, although we don't see a really strong, consistent breed link across the board in horses. One study did flag Appaloosas, though, and an interesting observation, at least in California, is that something like 80% of horses seem to show their first signs between September and February.
Yeah, the seasonal pattern is interesting. Okay, so you've got the microscopic battle. Now, what does this look like for the horse itself? What would an owner actually see?
Right, the clinical picture. It can definitely vary. Some cases are mild, others severe, some localized, some widespread. But that pattern of crusted, scaly lesions is usually pretty consistent. Now, technically, the primary lesions are those little fluid-filled blisters, the vesicles or bullae, or maybe pus-filled pustules. But like we said, they're incredibly fragile.
So you rarely catch them?
Very rarely. What you will almost certainly see are the secondary lesions that form after they rupture. The most obvious thing is usually thick, yellowish, maybe greasy, maybe flaky crusts. These build up from dried serum, inflammatory cells, skin debris. You'll also see scaling, that flaky skin. And then alopecia, the hair loss, which can be patchy or quite widespread. It happens either under the crest or maybe because the horse is rubbing from irritation. You might also notice raw areas, erosions, or ulcers, sometimes these little rings of peeling skin called epidermal collarettes, or maybe follicular casts, which is like keratin debris stuck around the hair shafts.
Okay, and where do these typically show up? Is there a pattern to where they start?
Yes, there often is. The lesions tend to be symmetrical, so appearing similarly on both sides of the body. Common places for them to start are the face, especially around the eyes and muzzle the neck, the main body or trunk, particularly along the top line and flanks, and the lower legs, so pasterns, fetlocks, and really importantly, the coronary bands.
Just above the hoof.
Exactly, and PF hits the coronary bands quite frequently. This is serious because it can lead to poor hoof quality, flaking hoof wall, lameness, and in really severe, long-standing cases, you can even see the entire hoof capsule start to slough off.
Oh, wow.
Yeah. And the lesions aren't just limited to haired skin. They can also pop up on mucous membranes or where skin meets mucous membrane around the eyes, lips, nostrils, vulva, anus sheath, or udder. And it's worth noting the disease can spread really fast. It might start small but cover most of the body within weeks or maybe months.
That sounds incredibly uncomfortable, potentially very painful. Are there signs beyond the skin itself? Systemic signs?
Yes, definitely. Especially in moderate to severe cases, the horse often feels generally unwell. You might see lethargy, just general depression, lack of energy, maybe anorexia that go off their feed, which can lead to weight loss. That might be from discomfort or just feeling sick. A fever, pyrexia, is possible. And edema, swelling often in the lower legs, stocking up, or under the belly or in the brisket area. Pain is common, and about half of these horses are also quite itchy, pruritic, which leads to more skin damage from rubbing and biting.
Makes sense.
And of course, if those coronary bands or lower limbs are badly affected, then lameness is a big sign. Just as a side note on who gets it, the average age seems to be around 8 or 9 years, but the range is huge, from just a couple of months old up to 25 years, and it affects males and females pretty equally.
Okay, so quite a range of signs. And like you said, some could look like other things: rain rot, ringworm, allergies. Which brings us to a critical point. How do vets actually nail the diagnosis? How do they confirm it's PF and not something else?
Yeah, that's crucial. It really takes a combination of things. A high level of suspicion based on the signs, a very thorough skin exam, and then specific diagnostic tests. Differentiating it is key. It always starts with a really good history from the owner. When did it start? How did it progress? Any other signs of illness? Any potential triggers they can think of, plus the vet's own observation of those characteristic crusts, the scaling, the pattern of where the lesions are. Then the vet needs to rule out the lookalikes. We call these differentials.
Right.
So things like dermatofillosis, that's rain rot, dermatophytosis ringworm, bacterial infections like folliculitis, allergies, maybe insect bite hypersensitivity, pastern dermatitis or scratches, even reactions to drugs, or, much more rarely, certain skin cancers. Ruling these out usually involves some pretty standard tests first, like skin scrapings to look for mites, maybe fungal cultures, bacterial cultures, basic stuff. Once those common things are hopefully ruled out, then cytology becomes really informative.
Which involves looking at cells.
Exactly. You take an impression smear, basically pressing a microscope slide onto a lesion or under a crust, stain it, and look at it under the microscope. The absolute key finding here, the thing that really points towards PF, is seeing those acantholytic keratinocytes. Remember those, the rounded up skin cells that have detached from their neighbors. Finding those, often surrounded by neutrophils, sometimes eosinophils, is highly suggestive of Pemphigus Foliaceus.
Okay, so seeing those specific cells is a huge clue. But what's the definitive test? The one that really seals the diagnosis?
That would be the skin biopsy followed by histopathology. That's considered the gold standard. The vet will take several small samples, usually 3 to 5 punch biopsies, about 6 to 8 millimeters, or maybe small wedge biopsies. The key is to get them from the right place. Ideally, an intact primary lesion, like a pustule if you can find one, or from under a very fresh crust, or right at the edge of an expanding lesion. And here's a really critical point for sample collection, something owners might notice. The vet should not scrub or aggressively clean the biopsy site beforehand.
Why is that so important?
Because doing that can literally wash away the diagnostic evidence. It can remove the crusts, the pustules, and crucially, those acantholytic cells that the pathologist needs to see to make the diagnosis. Gentle clipping is okay, but no scrubbing. Any cleaning for closure happens after the biopsy is taken.
Got it. They'll wash away the clues. So what does the pathologist see under the microscope that confirms PF?
They look for several characteristic features. Primarily, acantholysis, that separation of keratinocytes happening high up in the epidermis near the surface within the stratum corneum or granular layer. This creates clefts or spaces that become the vesicles or pustules. They'll also see inflammatory cells, mostly neutrophils, maybe eosinophils, filling those pustules. And then there's a really unique finding called tombstoning of basal cells.
Tombstone it.
Yeah, it looks like it sounds. The very bottom layer of epidermal cells, the basal cells, stay attached to the underlying dermis, while the cells right above them detach and float away. It leaves this single row of basal cells looking a bit like tombstones along the base of the blister.
Wow, that's a vivid image. Seeing that tombstoning alongside the acantholysis, that really points the finger at PF.
It's extremely specific, yes. When you see that pattern, the high level of acantholysis, the pustules, the tombstoning, it's highly indicative of Pemphigus foliaceus. It helps distinguish it from other things that cause crusting but don't have that precise type of cell separation. And getting that confirmation is vital because it tells you you're dealing with an autoimmune disease, which completely changes the treatment strategy compared to, say, treating an infection. The pathologist will also use special stains to rule out any underlying bacteria or fungi, just to be sure, especially since some fungi can rarely cause acantholysis too. Beyond histopathology, there are more specialized tests that may be less commonly used for initial diagnosis. Direct immunofluorescence, or DIF, is one. That uses a fresh skin biopsy, not one in formalin. It looks for the autoantibodies actually stuck to the cells in the skin. You often see this characteristic chicken wire pattern of fluorescence between the cells. It's very specific for pemphigus. Then there's indirect immunofluorescence, or AFEA. These are done on blood serum to detect antibodies circulating in the blood. They tend to be less sensitive for diagnosis in horses compared to biopsy, but they can sometimes be useful for monitoring how the disease is responding to treatment later on. And finally, routine blood work, a CBC chemistry panel, can provide supportive information. You might see signs of inflammation, like high neutrophils. In chronic severe cases, maybe mild anemia or low protein, specifically albumin. But often the blood work is fairly unremarkable or just shows nonspecific changes related to illness.
Okay, so it's the detailed process, but the biopsy and histopathology sound like the real key. Once you have that confirmed PF diagnosis, what then? What are the treatment options? Is it curable? Or is this long-term management?
That's exactly the right question. The focus of treatment is really threefold. Suppress that misdirected immune response, relieve the horse's clinical signs, and manage any secondary problems, especially infections. And it's crucial for owners to understand up front, this is almost always a long haul. Treatment is often prolonged, it can be challenging, and it frequently requires lifelong medication. We usually frame it as the disease being controllable rather than curable. That's probably the most important single takeaway for owners facing this.
Controllable, not curable. Okay, so what does that control involve? What's the main treatment?
The absolute mainstay of treatment is immunosuppressive therapy. And the first line, generally most effective drugs, are corticosteroids. Vets usually start with fairly high doses to get the inflammation under control quickly. For example, prednisolone given orally, maybe 1 to 2 milligrams per kilogram per day, or dexamethasone orally or sometimes injectably, maybe 0.1 to 0.2 milligram kilogram daily to start. The goal with these initial high doses is to achieve remission, meaning no new lesions are forming and the existing ones are healing. This usually takes maybe 1 to 3 weeks. Once remission is achieved, the really tricky part begins. Very slowly tapering the steroid dose down. The aim is to find the lowest possible dose, often given every other day, that keeps the disease in remission. This tapering process can take months.
A very gradual reduction.
True.
And that balancing act sounds crucial, especially considering steroid side effects. What are the big concerns there?
You hit it right on the head. It is a balancing act, and monitoring for side effects is paramount. The biggest worry with long-term steroids in horses is definitely laminitis, especially if the horse has risk factors or a previous history. Other potential issues include gastric ulcers, general immune suppression, making them more prone to other infections, and muscle wasting over time. Because of these side effects, sometimes we need to add other immunosuppressants, either to help get the disease under control initially, or more often, to allow us to reduce the steroid dose to safer levels, what we call steroid-sparing agents.
What are some of those?
Azathioprine is commonly used. It works differently, inhibiting immune cell proliferation. It takes a while to kick in, weeks or even months, and needs monitoring for potential bone marrow effects, though that's rare. Historically, gold salt's injectable gold compounds were used and can still be effective, especially maybe in younger horses, but they need careful monitoring too for kidney or skin issues. Mycophenolate mofetil is a newer option that shows some promise. Cyclosporine, which is used in small animals, is generally not practical in horses because it's very expensive and absorption is unreliable.
So it's primarily steroids, maybe with azathioprine or others added if needed. What about managing the skin itself and other complications?
Absolutely vital. Supportive care is key. This includes topical therapy using things like antiseptic shampoos, maybe chlorhexidine or benzoyl peroxide based to gently remove crusts and reduce surface bacteria. Sometimes topical antibiotics or steroids are used on specific spots. Moisturizers can help too. Systemic antibiotics are often needed because the skin barrier is so compromised, and the immunosuppressive drugs make secondary bacterial infections very common. Pain management is important, usually with NSAIDs like Banamine, Flunix, and Miglumin. Good nutritional support if the horse isn't eating well. Definitely proactive laminitis prevention, especially with the steroid use. Keeping the horse in a clean, dry environment is helpful. Maybe sun protection if there's pigment loss. And underpinning all of this is owner education and commitment. Owners have to understand this is likely a lifelong condition, requiring constant vigilance for flare-ups, meticulous medication administration, and monitoring for side effects. It's a huge undertaking.
It really sounds like it demands incredible dedication. Given all that, the long-term nature, the potential complications, what is the overall prognosis for a horse diagnosed with PF?
It's generally described as guarded.
Guarded, okay.
Yes. While many horses can be managed successfully, it's often not straightforward. Lifelong treatment is common, and relapses or flare-ups can happen even with the best care. There's some suggestion in the research that very young horses, like foals, might actually have a better prognosis. They seem to have a higher chance of achieving remission and maybe even eventually stopping medication compared to adult horses. In adults, PF tends to be more chronic, more progressive. You can usually induce remission with the initial high-dose steroids, but keeping them there on low doses can be the challenge, and many need continuous therapy indefinitely.
What factors make the outlook worse?
Several things can make the prognosis poor. If the disease can't be controlled even with high doses of medication, or if it requires doses that cause unacceptable side effects like severe laminitis or recurrent infections, extensive involvement of the hooves and coronary bands leading to persistent lameness or hoof sloughing is a very negative sign. And obviously just a poor overall response to the standard treatments. Sadly, for some horses where the disease is just too severe or the complications from treatment become overwhelming, euthanasia might become the kindest option to prevent suffering. But, and this is really important to stress with a dedicated owner who understands the commitment and diligent proactive veterinary care, many horses with PF can achieve a good quality of life and be managed effectively for a long time. It's tough, but often achievable.
That's a really comprehensive picture. We've gone from the immune system's mistake at the cellular level, through the often dramatic skin signs, the careful diagnostic steps, and right into the realities of long-term demanding management. It absolutely highlights that partnership between owners and vets.
It really does, and maybe connecting it to the bigger picture. It makes you think, doesn't it? Considering that huge commitment, the resources, the time, the emotional energy, the risk of serious complications. How do owners navigate that? How do they balance that deep emotional investment in their horse with the practicalities of managing a chronic, often relentless autoimmune disease like PF, always keeping the horse's long-term quality of life front and center?
That's a profound question, and one every owner in that situation must grapple with. A very powerful thought to end on. Thank you for joining us for this deep dive today.